This program is brought to you by Emory University.
Good morning, everyone. Welcome to our second Heart and Vascular Grand Rounds of this year. It is my pleasure to introduce Dr. Michael Lloyd, who is a professor and director of the Emory University Hospital EP Lab, also the director of Arrhythmia Device Clinic. Just that device clinic is so busy with over 10,000 people whose devices are managed there. He's also in charge of the educating the nurses and staff for that clinic. He's also the founding director of EP Clinic for Congenital Heart Disease and program director of our EP Fellowship Program up until recently. Dr. Lloyd did his medical school at University of Nevada and did his internal medicine and residency and was a chief resident there at Scripps Clinic in La Jolla, followed by his cardiology and EP training here at Emory. He's very active in the Heart Rhythm Society and the American College of Cardiology, especially more recently in the Digital Education Committee and Virtual Reality Working Group. Mike's always available to answer our EP questions. He's a gifted teacher. He's had over 125 manuscripts despite being a busy clinician. And today he's going to talk to us about wearables and AFib. I'll turn it over to you.
Thanks, Pooja. Thank you all for attending on this Zoom conference. It's interesting to me that this is sort of the new way of lectures, and I'm still not perfectly comfortable with it, but I'll do my best. These are my disclosures. Zoom, when we do these Zoom talks, Zoom tracks us, and I always find it interesting the data that they actually publish on these, and they show, of course, that baby boomers are more likely to join meetings, and if we're congruent with statistics, about 60% of this little scroll will have their cameras on, but if for some reason we have more Gen Zers, maybe it'll be a lot less. The ideal talk length is not supposed to be 60 minutes. It's supposed to be somewhere around 18 if you are a fan of the TED Talks. This young gentleman here is one of our fellows who was invited to give a TED Talk on the intersection of medicine and religion. I can't promise to be 18 minutes, but as I told Pooja, I am gonna not take the whole hour, which is probably good because this neuroimaging study shows areas of the brain that are significantly more active with in-person talks compared to Zoom talks. So if we're congruent with statistics here, a lot of us will have a disappointing lack of stimulation in your superior sulcus cortex and other regions, but I'm going to do my best. Today, I'm going to talk about wearable revolution and the implications for AFib. I need to qualify what I mean by wearables. I'm talking about any personal product that records physiologic data. Many of these are wearables, watches, rings, but some of them are phone-based. And so I want to include that in the discussion because, as we all know, cardia is a big part of this digital revolution. This next 30 minutes, I hope to prove to you these 4 or 5 points. One is that personal technology is more of a blessing than a curse for us, even though sometimes it doesn't seem that way. And that AFib monitoring right now is the biggest problem financially, ethically, and clinically for we cardiologists. I also want to talk about device-detected AFib. I'm going to dive in a little bit to pacemakers and defibrillators because I think incidental detection of AFib has a lot of parallels with these wearable devices. I'm going to talk about the dose response of AFib and stroke and the temporal association of AFib and stroke. And then finally, this is all a path to discuss an important clinical trial that was actually brought up in Grand Rounds here in this forum that by Rod Passman, and this is the REACT AFib trial. So let's start with Emory patients. This was last year, 2023. It's actually going to be in a JACC case soon by one of our good residents. And this is a 65-year-old with palpitations. And this is something, you know, we've all seen. This is the Apple Watch tracing showing a wide complex tachycardia. He calls the doctor on call, and the doctor on call astutely says, boy, that looks bad. And the patient was having symptoms. So he told him to come into the hospital. And indeed, in the hospital, the patient proceeded to have an electrical storm, a VT storm. He was diagnosed with ventricular tachycardia, had some structural heart disease, and ultimately underwent an ablation and a defibrillator that a year later successfully defibrillated a more malignant arrhythmia for him. So this is a win for the wearable device. But more commonly, we're faced with this. So this is a patient this summer, an 80-year-old woman who emailed me their screenshots of 6 hours of palpitations. And this cardia is showing, of course, an irregular rhythm. And now what do we do? So this is the clinical situation that we're facing. Cardias are wonderful, but they also have interpretations. And I'm going to talk a little bit about these interpretation algorithms. So here I'm going to show a quiz, and I'll reveal the right answer at the end of the talk. This is possible AFib. So this is the irregular rhythm. And you can see it's pretty high fidelity tracing. But this is sort of what the patient sees and what prompts the emails to us. And then the more common, besides irregular rhythms, the most common thing we see, and Dr. Taylor was mentioning this just before the talk, is a bradycardia rhythm. So bradycardia implies some bad thing, some danger. And, you know, it can be a problem, but these labels on these cardia devices from the AI algorithms really create more anxiety than good. So let's talk about what's out there as it pertains to heart rhythm in terms of tech. And this is ignoring a whole host of other ingenious monitors, such as the wearable glucose monitors and things like that. And I don't mean to offend any Apple engineers or Fitbit engineers, because some of these things are fairly clever, but there's nothing really terribly innovative or new about the ability to record heart rhythm on these devices. It's just that miniaturization and integration with the personal devices has led to the widespread application of these. There's an amplification and filtering of the ECG signal. Again, not new. It's just that you can compress it in the size of a ring, as shown in this Aura, or a Fitbit, or a watch, or even a metal plate. There's rapid wireless connection with larger processing. There's cloud-based programs that you can upload. There's entire websites that Cardia has that I strongly recommend against. And there's a whole host of other niche physiologic measurements, such as sleep hygiene, heart rate variability, and things that, you know, I'm not going to talk about. We're going to talk specifically about heart rhythm. But this is sort of the blessing and the curse for us. And I would submit to you that the blessing of these devices at its current state is that this is high quality raw data. So our patients now have the ability for a nice high fidelity single lead EKG that then you can access when they have symptoms. And right now, as it stands, and this will change, the curse is the AI interpretation attempts. And this is where the computer tries to read the signal. So the AI algorithms just simply aren't there yet. They diagnose and yes, scare the patient. And these things just need to have a very low false positive rate. And this is just not happening. The specificity, this is a series that's not published yet about wearable devices and that the AF detection algorithms. The specificity of these systems are poor. When you're talking about telling someone they have to take clinical action, 75% for the Apple Watch, the AliveCore 69%. And the sensitivity, even if you say, okay, well, let's use this as a screen. And of course, screens, you want to catch as many as you can. The specificity doesn't matter, but even the sensitivity is not great. So the AI, the interpretation, and the labels that are seen on these devices we need to tell our patients to either ignore them or at least take them with a grain of salt. An EP is giving this talk, so I want to restrict the wealth of data that we could talk about specifically to device-detected AFib. And what we don't know is whether device-detected AFib in a pacemaker is similar to a device-detected AFib on a watch or a monitor, but there are a lot of parallels between this, and I want to delve into the data a bit about this sort of device-detected AFib from pacemakers and defibrillators. The first question I think we have to know is whether or not these incidental findings of AFib are meaningful. Do they mean anything? And I think the overwhelming answer is yes, these are meaningful. You know, we say, well, so what? You know, it's too much, it's information overload. But if you look at trials, and this is a combined analysis of a lot of incidental device-detected AFib, it's very clear that the risk of stroke is higher in these individuals. So this is 5 prospective studies, including 10,000 patients, and it's definitely associated with stroke. Now, the question is whether or not you can time it with the AFib or whether or not you can quantitate it with the AFib. Is there a dose response or a temporal relationship? This is a trial that is from our group, and I think Faisal Merchant is the senior author, showing that we looked at all the pacemaker detected and device detected AFib. We were unable to demonstrate a relationship between the overall burden of AFib and new stroke, or the longest single episode of AFib and new stroke. So it's really difficult to say if you have 6 hours of AFib, you're not at such a high risk versus 24 hours versus 2 minutes. The latest information on device-detected kind of incidental discovery of AFib came out with a pair of 2 papers in New England Journal 2023. The first was the NOAA AFNet. This was a randomized trial of people with 6 minutes or more of incidentally detected AFib and very high CHAD scores. And they said, well, should we take action with these things? Should we actually give patients blood thinners? And this is a question that comes up repeatedly in our inbox every day. And they looked at a combined endpoint of stroke, systemic embolism, or death, and found that there was no significant difference in this combined endpoint over 5 years. And there was a significant increase in major bleeding. So this led some people to say, well, we shouldn't really act on these incidental device-detected AFibs. But hang on, there's more to this story. The Artesia trial didn't combine a bunch of endpoints, but rather just looked at ischemic stroke in isolation, which is really what we're trying to get at. And this was a double-blind, dummy study, 6 to 24 hours of incidentally device-detected AFib, CHA2DS2-VASc of 3. And indeed, there is a significant reduction when you randomize them to Eliquis or apixaban versus aspirin in ischemic stroke. Granted, the absolute effect size is not terribly high. It's 2 to 3% over 6 years, but it is significant. They also showed that, yes, major bleeding events happen more in the blood thinner arm, but these patients frequently were handled with conservative measures or a transfusion, and the number of fatal bleeds in the Eliquis group was equal to the number of fatal bleeds in the control or aspirin arm. So, should we take action on incidentally detected AFib in our patients that would otherwise have an indication based on CHA2DS2-VASc for anticoagulation? I think to prevent ischemic stroke, the answer is yes. To prevent all-cause mortality, probably not. But if you really want to prevent a stroke, I think the answer is yes, at an acceptable bleeding risk. So it's not super clear, and there are a lot of reasons for this. There's a really nice paper from Ross Sanders in Australia, and they kind of explain why it's been difficult to relate the specific timing and duration of AFib to the stroke event itself. They found that cardioembolism represents only 73% of ischemic strokes, and that's kind of not too hard to swallow, because remember, AFib patients have atherosclerosis, hypertension, and so they're not excused from having non-cardioembolic atherosclerotic strokes, which should have nothing to do with AFib itself. In their study, only 17% of the strokes occurred during an episode of AFib, and they found that about a third of all strokes in patients with subclinical AFib, only a third has some sort of AFib in the preceding 30 days of stroke. So can you really say that it's the AFib that's causing the stroke, or is it a marker for stroke in a high CHA2DS2-VASc patient? Is there a dose effect or a dose response, and is there a temporal association? My favorite trial on this is this case control that came out in CIRC, and it was done in VA patients. And it took patients that had an ischemic stroke, had an acute ischemic stroke that also had a device, and they looked back in time in the preceding 30 days to see their AFib burden. That was the case. And then the control was the preceding 120 days to 90 days, so several months prior, and if they had AFib at that time, and that was the control period. And they found that in patients that had acute ischemic stroke and AFib, this is the individual cases, there was clearly a temporal relationship to the AFib and the stroke itself. And this is the crude odds ratio of that, showing that you're much, much higher risk of having the stroke within 1 to 5 days of having your AFib, and it tails off as you get further out. So there probably is a temporal relationship to atrial fibrillation and the stroke. It's important to remember that all of the data I spoke about were in people with defibrillators and pacemakers, and it may not mimic what we will get with wearable devices. But I think we're going to have some important and really nice data on a more global scale about how to react to AF detection, be it by watch or cardia. And we're on the precipice of some really super large studies to validate this. I think that the Apple Watch trials and cardia trials will more likely reflect clinical episodes, because that's when people are likely to check. And I think it'll be a larger population. It will still be a restricted population because it's those who can afford these devices. But I think it'll also include people with less comorbid conditions. The big data is coming, and they're refining their algorithms. So there will be a time where the actual interpretation of the wearable devices will be accurate. This is to the Fitbit heart study and the Apple heart study. Almost 500,000 patients, really big data, showing that their positive predictive values in this global just populational study is pretty good. In the Fitbit heart study, 98.2% to diagnose atrial fibrillation, and in the Apple heart study, 84%. So what now? I think at this point right now, we have great raw data from these wearables for diagnosis and rhythm symptom correlation. I think the benefit is that this is going to assess the global population, not just people that have monitors because they have, a pacemaker, or they have AFib detections because they have their pacemaker or defibrillator, and it'll better describe the AFib burden in total. The disadvantage is that this is going to accelerate some health disparities, because people that have access to these wearable watches and cardias are going to be the people that will be studied and will be treated. I think the disadvantage also is that there's worsening of patient anxiety because of the diagnoses that pop up on these devices. And right now, we do not have data, only signs and parallels with pacemakers to guide therapy based on what these things show. And there's no formal integration with the electronic medical record. So Emory has to get involved with how we're going to deal with this. And this will be important for us to get ourselves involved with. And I'm going to make a plug for this REACT trial, which Dr. Passman already mentioned in great detail in one of these grand rounds. This is the REACT trial, the rhythm evaluation for anticoagulation therapy for atrial fibrillation. It is a 1-to-1 randomized trial, either to chronic DOAC or watch-guided targeted DOAC. And so what they're doing is saying, every day we're going to monitor you, and if you have AFib, your phone is going to say, this is going to be the clinical action. You're going to take your DOAC for 30 days, and it's going to assess the non-inferiority, ischemic stroke, arterial embolism, and all-cause mortality compared to continuous DOAC. And then the secondary endpoint is, hey, if we do this as needed, can we reduce major bleeds? The target is 5,300 patients at 80 sites. Emory is one of them, and the follow-up is 3 to 5 years. It is NIH funded, and enrollment started in July, and it's a challenge. It's a challenge to enroll, but there are a lot of patients that you see that could be eligible for this trial. These people should have non-permanent AFib, and they should probably not have a ton of AFib, because if they have a ton, their watch is going to tell them to take Eliquis all the time. Their CHA2DS2-VASc needs to be 1 to 4. Obviously, they can't have a prior stroke. The participant should be on a DOAC at the time of the screening, and they have to be able to deal with these phones and Apple Watches. The study will provide the Apple Watch, but they have to be in possession of an iPhone. This is hopefully going to be expanded to Samsung platforms in the future, and they have to be willing to wear this smartwatch around 14 hours a day and be around cellular service about 80% of the time. The clinical sites will get monitors to make sure that their AFib isn't too extensive, and then they'll be randomized. They'll then go to a central sort of hub. This is Stanford-based, that will kind of manage how the notifications are given. If they detect AFib, they will get a notification on their iPhone saying, hey, we've seen AFib, start taking your blood thinners. And then the study participant will either click, yes, I will take them, or no, I can't, and then they'll go from there. But there will be these constant interfaces. And in this way, every day we'll assess, and every day we'll have feedback with the patient and guide the blood thinner dosing. There's notifications as shown here, and this trial will resolve this whole question of if AFib is really a cause, because we're going to be using the blood thinners as needed, or is it just a marker? It will also be assess reducing time on anticoagulation. Is this going to reduce our bleeding complications? Will it reduce cost of the total cost burden on the patient, which is a constant concern? And will it improve the quality of life of a patient not having to take their DOAC continuously, and just have some other way, some phone-based way of telling, of guiding what you do day to day. It will change indications for rhythm control. It will, right now it's about improving symptoms, but in the future it might limit exposure to lifelong anticoagulation. And it will assess how we can integrate what all of our patients have more formally into our clinical practice. Because right now there's 1,000 different ways we all handle this. And I think it's important to formalize this. So here's those 2 cardiac quizzes, just to show you what you can get from these devices. Beautiful raw data. This possible AFib is an irregular rhythm, widely irregular. Here's, 30 beats to 70 beats, but there are definitely P waves here. So the P waves, all the clinicians can see, the AI algorithm cannot see. And this is actually a cardia on my dog. Dogs have incredible sinus arrhythmia, and will have these super irregular heart rates. But I'm not going to give poor Ralphie Eliquis based on this tracing. And then, of course, we have the other plague, the bradycardias. Oh my gosh, I'm bradycardic. Do we need a pacemaker? Well, that's just me relaxing. You're going to have heart rates that are slow. So I hope to God no one gives me a pacemaker based on this single cardia tracing. In conclusion, I hope I demonstrated to you that personal tech is more of a blessing than a curse. The raw data is beautiful, and the AI will come as on the basis of machine learning and the data feeding, the AI will refine itself and be accurate. It's not there yet, but it will be. We all know that AFib monitoring and reporting is the largest clinical arrhythmia problem for us. I hope I demonstrated that device-detected AFib is associated with increased stroke. The data would suggest that based on pacemakers and defibrillators, and there probably is a temporal and dose-related association between AFib and acute ischemic stroke. The amount of AFib still is argued even in our circles, in our journal club, but there probably is some dose effect. And only trials like the REACT trial may answer these questions. And I would love for anyone that has a patient that is tech savvy to either email me or Thomas Prizer or text me if you have patients that you think would be excited to participate in this clinical study. And with that, Pooja, I will conclude. Thank you very much for your time, and I'll be happy to answer any questions if there are any or comments.
Great. Thank you so much for walking us through that very clinically relevant topic, something that we see all the time in clinic. I'm going to open it up for questions. Is there, while we're waiting for people to type in their questions in the chat, is there a particular device that you like? Because patients will ask, which one to purchase amongst all the ones versus AliveCor versus Cardia, based on that table that you showed.
The single lead EKG technology and Cardia and AliveCor are great. The Fitbit is okay too. I think all of them are about equal, Pooja, as far as the raw data. The Apple Watch incorporates photoplethysmography in their algorithms. So if you wanted a more accurate algorithm, that's probably better, because then it incorporates pulse and rhythm, so it can sort of weed out some artifact. But I really like them both. My advice to patients is, if you get this device, and it's really helped establish a lot of diagnoses for us, but if you get this device, just like we do on the EKG, ignore the interpretation. But if you have a clinical issue, you can send me the raw data. I usually recommend not signing up for the websites or anything like that, but send me the raw data either through the portal, or I use email. Is probably not a HIPAA thing, but it's through the portal you can do it, and you can have your diagnosis. It's been miserable for the Holter monitors companies, because these are far better.
But for Cardia, don't you have to be symptomatic? I mean, wouldn't that be the time that it would be most helpful, right? Because for people who are having symptoms of palpitations, then they check
Yes,
versus people who are having asymptomatic things.
I hope so. But just like blood pressures, people tend to just check obsessively and repeatedly. So I think Cardia may be more of an event monitor, and Apple Watch may be a MCOT sort of thing, but I kind of feel like both are being used in the same way.
Mm-hmm. Okay, thank you. Sheila Gilchrist has a question. How simplified are the instructions for use of these devices?
They are simple enough, and they're usually on your phone. They show up on your phone. So if you know how to use the phone, they're simple enough for my most Luddite of patients. So even super older people who are used to flip phones can use this. There's really not much to it.
Okay, great. Bob Taylor asks, any pearls on how to get less noisy baseline signals with Cardia Mobile and other devices because of the irregular baseline?
Yeah, The cardia, that's a great point. The cardia is prone to baseline wander, and if you are trying to walk and record your EKG, it's going to be uninterpretable. I like the 6 lead, Bob, because I think, I mean, it's a little more cumbersome because you got to touch your leg skin or your belly skin. But I think when people hold the 6 lead in that way, it makes the artifact a lot less because they're actually physically kind of tamping it down on something, which gives you the a benefit of extra leads too. But that's sort of that's my one trick or recommendation that I use. But it is important to be very still. There was Modele asked mentioned about this Tequity thing. Tequity is a hot topic about this. We just had this meeting in Atlanta called HRX, which is a tech sort of heart rhythm thing, and this, there's a lot of think tanks about how to make these more available to everybody. And I really don't have a good answer, unfortunately. I think these trials are one way, because okay, maybe you don't have a phone, but although I think most people in the US have smartphones, that the trial will at least provide the watch for free, but it's an important issue. And I mean, this is not reflective of, a developing country sort of population.
There's a question from Francisco. Thank you so much for the talk. For the REACT trial, since intervention depends on the device detecting AFib, which device are they using?
This is right now, and I'm hoping it's expanding, but this is right now with the Apple Watch. So the single lead EKG that you hold your finger to, and it gives you kind of limb lead 1 and the interpretation.
I have a question. So, sometimes we get consults about, we get a lot of consults about AFib that's in the ICU or incidentally discovered in peri-op setting, et cetera. Are you telling patients that, when they go home, purchase one of these devices if they're able to help make the decision about, duration of anticoagulation in that setting?
My spiel is that anybody with an arrhythmia is probably better off having a Cardia or an Apple Watch if you want, but Cardias are cheaper. Speaking of Tequity, I mean, that's $60. So I think, yes, I do kind of globally recommend it. It's tough because, who's responsible if something is missed, and who's medical legally responsible for this, I think is an important question that I don't have the answer to. But yeah, I tend to tell everybody to get it.
Okay. Did Dr. Bayer have a question?
Yeah. Thanks, Pooja. So I got two questions. One, those trials that you're talking about, Mike, were like 6 hours of the cutoff. We see a lot of these like 1 to 2 minutes of asymptomatic AFib on monitors. Is there any cutoff that you have in terms of when to do something about it? And then my second question is, how did you get your cardiomobile on your dog? How did you do that?
Well, you put the pulse on the 2 electrodes. That's all.
Right, I'm going home.
That's
what I'm doing. As soon as I get home, I'm putting both my dogs on.
You'll be startled by how irregular they are. But first of all, thank you for turning on your camera. We can tell your age based on that. But second, the dose response question is challenging. There's a lot of trials that showed no difference in 6 minutes, 6 hours, or 24 hours. There are trials. And Faisal actually gave a talk a long time ago that really outlined this nicely. So it's difficult. Those time cutoffs were basically arbitrary to say, I just want to weed out, you know, under detection by the or weed out the noise by the pacemakers. But there's post-analysis data that shows there's probably the biggest cutoff, Jeff, for over 24 hours. And this is, I think, some subsequent analysis of ASSERT data. Over 24 hours is really where you get the bang for your buck as far as risk compared to less than 24 hours. So it's all over the map. Even if you ask EPs, how much do you need to start to throw Eliquis at somebody? But if you're going to use a rough guide, over 24 hours is really the big one, and less, it's much less clear. I also use CHA2DS2-VASc because if your CHA2DS2-VASc is 7, and there's data for this, I mean, you could take CHA2DS2-VASc alone and predict who's going to have a stroke, irrespective of AFib. So that's also something that helps guide that decision if you're sort of on the fence.
Great, thanks.
Any other comments or questions?
Hey, Mike.
Yes.
Steve Clements. Thanks so much for that great presentation. It's always a question that comes up. We're always puzzled when folks say that there's been 6 seconds of atrial fibrillation on the monitor. But there's this vast group of people out there who have strokes. And we start looking at them with TEE, we don't find an etiology. Start looking at the left atrial appendage, look to the velocity to see if there's any clue to like low velocity where the atrial appendage mechanical function may be temporarily paralyzed after atrial fib. We hardly ever find anything like that. We occasionally see somebody with sinus rhythm and hardly has any velocity in their left atrial appendage, and that brings up another question about what the etiology of all that is. But
Right.
you know, this might give us some clues to that group of patients that we come up with no answer to, which is a vast number out there that come off the neurology service, do a TEE and find nothing. So I'm all in favor of doing this, and congratulations to you guys for doing it.
Yeah, the nice thing about all of these wearables is it really is going to open the door on a population level of how much AFib is out there. So we'll get the denominator. You know, I think we'll have a better idea of the denominator and really refine stroke risk, at least for those who can acquire this sort of personal technology.
One other comment, I've found that if you like put the Cardia on your leg and try to, and the simple one I think is, to me, is better, but if you put the 2-lead one on your leg, you get some artifact. You'll take them, put their hands over on the table. You have to tell them not to touch their thumbs for what that's worth. Put it on a stable surface and try to relax your fingers. You get the best tracing from that. Yep.
Good point.
So in that scenario that Dr. Clements just mentioned, do you prefer to do a loop recorder after unexplained stroke, or do you just tell people to invest in Cardia, or some kind of a wearable?
Well, the question of cryptogenic stroke is kind of a different animal. I again would always advocate for personal technology because I feel like the raw data is good. I don't think there's much of a downside to it. But for stroke, I mean, the stakes are higher. So those are people that usually get their long-term monitor, and then we end up putting an implantable loop recorder because the fidelity and the published data is better for that.
All right. Thank you very much again for taking
Thanks.
the time. And thank you everyone for joining. Don't forget to get your CME. And I will see everyone next week.
The preceding program is copyrighted by Emory University.